Before hospitals had billing desks and before insurance cards decided who received care, survival in America depended on something far older and more fragile: other people. In 1900 America, illness did not arrive with paperwork, deductibles, or emergency room bracelets. It arrived suddenly, through a fever in the night, a crushed hand at the factory, a cough that refused to fade. And when it did, families could not call an ambulance or check an insurance network. For most Americans, hospitals were rare, distant, and often feared. Instead, survival rested inside homes, churches, neighborhoods, and an unspoken system of shared responsibility that filled the gaps where institutions did not yet exist. At the turn of the century, fewer than 10% of Americans had anything resembling health insurance. Most hospitals were charitable institutions meant for the poor, immigrants, or those with nowhere else to go. Middle-class and working families avoided them if possible. Being sent to a hospital often meant that recovery was unlikely. Medical science was improving, but antibiotics did not exist, anesthesia was limited, and infection was a constant threat. For many families, home was not only a place of comfort, it was the primary site of medical care. When sickness struck, the first responders were not doctors but family members. Mothers, daughters, and wives became full-time caregivers overnight. They boiled water, cleaned wounds, prepared herbal remedies, and monitored fevers through long, sleepless nights. Medical knowledge traveled through generations, passed quietly from older women to younger ones. They knew which teas could ease coughing, which poultices reduced swelling, and how to keep a sick room ventilated to prevent bad air, which many still believed caused disease. Doctors did exist, but they were not always accessible. In rural America, a physician might live miles away and travel by horse, arriving hours or even days later if the family could afford the visit. Payment was often flexible. A doctor might be paid with cash, farm produce, labor, or nothing at all if the family was struggling. In tight-knit towns, doctors relied on reputation and trust rather than contracts. They knew who would eventually pay and who could not, and many treated patients regardless. But even doctors could not replace what communities provided. When illness entered a household, neighbors noticed immediately. Smoke stopped rising from the chimney, children failed to appear at school, or laundry lines stood empty. These small signs triggered action. Women arrived with baskets of food. Men took over farm work, repaired fences, or covered shifts at local shops so the family could focus on survival. No one asked for permission. Help was assumed. In immigrant neighborhoods, this reliance on community was even stronger. In cities like New York, Chicago, and Boston, entire blocks were formed by people from the same villages overseas. They shared language, customs, and an understanding that survival in a new land required unity. When someone fell ill, collections were taken up within days. A few cents from each household could cover rent, medicine, or a doctor's visit. Churches and mutual aid societies played a critical role, acting as informal insurance systems long before the government recognized the need. These mutual aid societies were everywhere in 1900 America. They went by many names: fraternal organizations, burial societies, lodge associations, but their purpose was similar. Members paid small monthly dues, and in return, the group provided financial help during sickness, injury, or death. If a worker was injured in a factory accident, the society might cover lost wages. If someone died, it ensured a proper burial, sparing families from debt and shame. For many Americans, these organizations were the only safety net they trusted. Workplaces themselves sometimes became sources of support. In dangerous industries like mining, railroads, and factories, accidents were common. Employers were not legally required to compensate injured workers, but informal systems often developed. Co-workers passed the hat to collect money. Families shared meals with injured men who could no longer work. Children were pulled from school to contribute income. Survival required sacrifice from everyone, including the youngest. Children in 1900 America understood illness differently than children today. They were not shielded from it. They fetched water, ran errands for medicine, cared for younger siblings, and sometimes watched death unfold in their own homes. Yet this exposure also taught responsibility early. Family loyalty was not an abstract value. It was practiced daily, often under pressure. When parents became ill, children stepped into adult roles without question. Faith communities also filled critical gaps. Churches were not only spiritual centers, but logistical hubs. Ministers organized meal rotations, announced needs during services, and coordinated caregiving. Congregations knew who was struggling and who could help. In times of epidemics, such as tuberculosis outbreaks or influenza waves, churches sometimes served as makeshift clinics or quarantine spaces, despite the risks. Epidemics revealed both the fragility and strength of this system. Without modern medicine, diseases spread quickly. Families isolated themselves when possible, but total separation was rare. Caregivers continued their work, often at personal risk. Communities mourned together, buried their dead, and helped surviving families rebuild. Loss was common, but abandonment was not. One of the most striking differences between 1900 America and today was how little privacy existed during hardship. Illness was not hidden. It was visible, communal, and shared. While this meant less control over personal struggles, it also meant fewer people suffered alone. Loneliness, as we define it today, had less room to grow when survival depended on connection. By modern standards, this system was imperfect and often unequal. Women carried disproportionate caregiving burdens. Minorities and immigrants received uneven treatment. Medical outcomes were uncertain. Yet within these limitations existed a deep culture of interdependence. People knew that one day they would need help too, and reputation mattered. How you showed up for others shaped how others would show up for you. As the 20th century progressed, hospitals became safer, insurance systems expanded, and government programs emerged. These changes saved countless lives and reduced suffering. But something else slowly faded: the expectation that neighbors, extended family, and community would be the first line of defense. In 1900 America, survival without hospitals or insurance was not easy, but it was possible because care was not outsourced. It was personal. It lived in kitchens, church basements, tenement hallways, and quiet acts of service that were never recorded. Families survived not because the system protected them, but because people did. And in that world, health was not just a medical condition, it was a shared responsibility, carried collectively in an age when community was not optional, but essential.